Hi everyone, welcome back to another session for the free NCLEX review class today. And for those who just joined us, we are on the 34th day of our review sessions. We are offering this 90-day free NCLEX review classes. And we are also inviting you to enroll in our comprehensive NCLEX review course, Stancoast NCLEX Coaching. And you can access over 50,000 NCLEX style questions and 10 hours of animated videos for flexible study. And we are going to be able to provide you with our on-demand video library that is included in our offering. And we're going to invite you to check out into that website at www.stancoastnclexcoaching.com. And please check down on description box below. We also appreciate all your comments and feedbacks, so kindly post them in the section below. Now, we're going to have to talk about our topic today on the valvular heart disorders. All right. Now, as you see here already, this topic really will talk about the different defects that can involve the different chambers, or the different valves rather. This could be the mitral, the aortic, tricuspid, or the pulmonic valves. And this can somehow lead into the complication, which is going to be the congestive heart failure. Now, with these problems here, the valves cannot probably open or close properly, and eventually it will lead into that heart failure in the long run. And we're going to have to classify the different types of heart disease, or the valvular heart diseases. And the first one here is the stenosis, okay? And this is referred to as the narrowing of the heart valve. And this is going to make the passing or the flow of the blood difficult, okay? And there's also that type where it's referred to as insufficiency, wherein there is now an improper closure of the heart valves. And this simply means that the valve doesn't close tightly, and then this will allow the blood to leak backwards. And this is going to be referred to as the regurgitation, okay? So please don't get confused about the stenosis and the regurgitation or insufficiency, all right? So like I've said earlier, stenosis is basically caused by the narrowing of the heart valve, and this will slow down the forward blood flow. Okay, so there is that resistance of the blood flow inside the heart chambers. Now, for the insufficiency or the regurgitation, this can allow the blood to leak back. It will go back up into the previous chamber, okay, such as the backflow of the blood from the left ventricle into the left atrium. Okay, now here we have the different causes of the heart valve problems. One of those is the congenital problems or anomalies. So some people are born with those heart valve problems that can affect any of the four valves. And some of these people probably would have the acquired type of cause. It could be a degenerative type of a problem wherein it's caused by wear and tear of the years. Maybe this is going to be caused by high blood pressure. And I'm saying chronic high blood pressure, and also probably rheumatic heart disease, which comes in as a result to a long-term inflammation that will cause the valve to stiffen, and they will not be able to work properly as well. Now, there's also what we call as infective endocarditis, and this is going to cause the heart valve problem. And I want to remind you that this is being caused by the bacteria or other germs that may infect the heart valve and will cause damage to the leaflets, okay? Now, there's also illicit use of IV drugs, and this can lead into the tricuspid valve problem, okay? So please take note of that. This is something that is rare, but like I said, it can be caused by, the heart valve problem is caused by the drug abuse. Now let's move forward with the different risk factors here. One of those risk factors is the common hypertension. And so when this is going to be consistently high, it can strain the heart valve. It can lead to permanent damage. Another is the rheumatic fever. This is going to result to mitral stenosis and also insufficiency. We also call that as a mitral valve regurgitation. And this is caused by the bacteria, like a strep throat infection. Okay. Strep throat infection. Rewrite that. Streptococcal infection. Probably like a pharyngitis or tonsillitis with a strep throat microorganism. This can lead to that rheumatic heart disease. Try one more time. Okay. All right. Now, if the person does not have proper treatment with that strep throat or bacterial infection, it can lead to that mitral valve problem. And of course, the body will have that kind of like autoimmune response wherein it will attack the heart valve itself, thinking that it's the bacteria. And so it will lead to that mitral valve regurgitation and also stenosis. Now, another is the infective endocarditis. What is that? Well, like I've said earlier, this is going to be caused by another bacteria that is going to lead to problems. Same thing, it's going to target the heart valves. And we also have the congenital malformations wherein people are born with the defect, and this will eventually lead to the heart failure if not treated. And another is the Marfan syndrome, which is a connective tissue disorder that can also affect the heart valves and the other areas of the body. And this is a genetic disorder that will affect several organs. Okay. Now, another is the aging process, which is going to be attributed to the calcification, especially in the elderly. We're talking about the calcification and also atherosclerosis and with the calcium deposits and the plaques build up in the arteries, this can also get deposited into the valves, right? And this will make the valves so stiff that it will be less flexible, and it will affect its ability to open and close properly. Now, we also have some problems with like papillary muscle dysfunction. Okay, so this is going to happen in the aging process. So what's going on here? Well, the muscles really is supposed to help the valves close, but if they're not going to be able to work properly, it can also lead to the heart valve malfunction. And like I've said earlier, there's that infective endocarditis. The elderly are also going to be prone to developing this, especially that they're going to be at risk for those infections, and eventually will lead to the valvular heart disease as well. Now, let's talk about the expected findings in a person with a valvular heart problem. And so in general, what's going to happen is that the person will not automatically or will not show the symptoms right away. And these are going to show up only when the disease has advanced significantly. So that's kind of a downside. I mean, it's a disorder, but the symptoms will not usually appear early on. It will only appear when the disease has progressed. And there will be murmurs that can occur because of the turbulent blood flow. And the timing of the murmur can also be either in the diastolic phase or the systolic phase. And this can also aid in the diagnosis what kind of valve is being affected here. Okay, so it could be a diastolic or a systolic murmur. And we will talk about this in detail later on. All right. Now, there's also different severities of the murmur. And some clinicians will also have some grading from grade 1 up until grade 6. And so when we are talking about grade 6, it's gonna signify that the murmur is getting so loud that it can be heard with a stethoscope or just by touching the chest. And this is going to be associated with a palpable thrill, okay? But this is not going to be asked in the NCLEX anyway. But with the left-sided heart valve damage, this can lead to more problems. It can cause the pulmonary artery hypertension, and it can also lead to the right-sided heart failure in the long run, okay? There's also left ventricular hypertrophy. There's also decreased cardiac output because of the congestive heart failure that has already set in. And yeah, as the disease is progressing, the more difficult it's going to treat. But we do have some different treatment modalities. We also have some surgical procedures that can treat that. But again, early diagnosis would really correct the problem. Now, we will compare the different assessment findings in the left-sided valvular damage. And so we're going to compare between the four. We'll start first with the mitral valve, okay? So when we are talking about the mitral stenosis, all right, we are talking about that valve that is located in between the left atrium and the left ventricle. And just going to show you the picture about this right here. When we are talking about the mitral stenosis, again, the problematic valve is in between the left atrium and the left ventricle. And so when we are talking about stenosis, there is that narrowing. It will not readily allow the blood to get transported from the left atrium into the left ventricle. And so there will be limitation in the forward flow. So there will be a significant residual blood volume in the left atrium. And what's going to happen is that the person will manifest that diastolic murmur. And this is going to be heard in the apex of the heart, okay? So this is going to be characterized as very turbulent blood flow in a very narrow mitral valve, okay? And why is it called diastolic murmur? Well, it's because the turbulent blood flow will occur when the heart or the ventricle relaxes, okay, during the diastolic phase. And so this is heard best listening into the apex of the heart, and it will be loudest, or it will be heard during the diastole. Now, the person here will end up with shortness of breath. And of course, this is associated with the exertion as well. And the reason for that is because of the decreased cardiac output, okay? Decreased cardiac output. So the body is sensing that the heart is really not providing enough oxygen to the body tissues. And so the lungs will be tasked to, hey, we really want you to work harder so you can supply more oxygen to the system. But that's not really going to help. It's just going to make that person exhausted with the tachypnea, right? With the use of the accessory muscles. So it's just a compensatory mechanism. It doesn't really going to help. Now, another manifestation here is the orthopnea. So the person here can only assume a comfortable spot when they're breathing. They're only going to be able to assume that comfortable spot when they're sitting upright. And this is caused by the pulmonary congestion. The person will have difficulty of breathing when they're in a flat or supine position, okay? Now, the person may also manifest irregular heart rhythm, atrial fibrillation, and this is caused by the atrial enlargement, okay? Let me put it right there. Due to the atrial enlargement. Okay, and why is there an atrial enlargement? Well, remember that the mitral valve is stenos. It's stiff. It's calcified. So what's going to happen? The blood will eventually stay much longer in the left atrium, right? There will be buildup of blood into this chamber. Over time, this will now enlarge and will lead into the irregular heart rhythm, atrial fibrillation. Okay. Now we're going to move forward with the next manifestation here, palpitation. Well, why is a person going to manifest the palpitation? This is basically the sensation of that bounding pulse in the chest. And of course, this is because of the increasing atrial pressure. The person will also end up with a fatigue because of the decreased tissue perfusion in the system. And you'll probably wonder here now, guys, that the person will end up with a jugular venous distension. And we are talking about the left side of the heart. But why is there a jugular venous distension in this person? Well, the reason for that, it's because over time, when there is going to be more problems occurring caused by the mitral valve stenosis, it will cause dilation, enlargement of the atria, and of course, this will add to a backflow pressure into the pulmonary veins. Remember that the pulmonary veins are those blood vessels that actually transport blood from the lungs after it oxygenated the blood. And so what's going to happen, the blood in the atria, over time, it will now cause backflow into the lung tissue, okay? And it just doesn't stop there. When there is going to be pulmonary hypertension because of the backflow of the blood coming from the left side of the heart, this can also cause stress into the right side of the heart. Okay, so let me just put a diagram here. Left atrial enlargement. It can lead into pulmonary hypertension because of the backflow. Pulmonary HTN, in short for pulmonary hypertension, and then this can cause that increased pressure into the right ventricle. It will strain the right side of the heart, or the right ventricle. Okay, and over time it can also lead into the congestive heart failure to the right side. This is what we call as the cor pulmonale. And remember that when there is now a problem into the right side of the heart, it can now also lead to the buildup of fluid into the venous circulation. And that is why the JVD is going to develop here. So basically the JVD will occur towards the late stage, in the more severe stage, okay, because it's now involving the right side of the heart. Now let's move forward into the next manifestation here. There's also the pitting edema, and the rationale for that is pretty much the same reason I gave for the JVD. There is now that right-sided heart failure as a complication to the left atrial enlargement or left-sided heart failure, leading to pulmonary hypertension and then complicating into the right-sided heart failure as well. And so the person will develop the pitting edema, bilateral lower extremity edema. There's also going to be hemoptysis. Hello, everyone. Welcome back to our class. And the hemoptysis is basically caused by the increased pulmonary venous pressure. Caused by increased pulmonary venous pressure. Okay. Once it does that into the pulmonary circulation, it will cause that leaking of the blood into the alveoli, and that's why they're going to end up with coughing up red sputum or blood-tinged sputum. Now, even though they probably would develop either that or maybe a dry cough, in some cases, the patient will probably just have the dry cough, okay? So it's not like a cookie cutter that everyone should have hemoptysis, everyone should have a dry cough. But in some instances, people will develop the dry cough, and this is because of it's not because of the fluid directly found inside the lungs, causing irritation. But this is caused by, or this is a result to, as a response to the increased pulmonary venous pressure. So this is what we call as reflexive response to the pulmonary venous pressure. So they're going to have that dry cough instead of the productive cough. With that elevation of the pulmonary venous pressure, this can now stimulate, it can irritate the stretch receptors and will irritate the airways. Again, this is a reflexive response that will result due to the pulmonary vein hypertension, and this will cause stretching of the pulmonary receptors, and it can now irritate the airways, triggering that cough reflex. Now, another manifestation is the PND, the paroxysmal nocturnal dyspnea. And this is something that we talked about in the previous session. This is the sudden onset of breathlessness when the patient sleeps, and usually will happen 2 hours after they have fallen asleep, usually after the first or second stage of sleep. And this is closely associated to the pulmonary edema. Okay, let me erase this. Associated with the pulmonary edema. Alrighty. And then lastly, we have the hepatomegaly. So this is the enlargement of the liver tissue. And again, associated with the right-sided heart failure as a complication to the pulmonary hypertension and also the left ventricular failure. Associated with right-sided heart failure. So again, guys, this is going to be during the later stage, as we know that the problem started in the left side of the heart. Okay, left side of the heart, and then it led into pulmonary hypertension. And with that pulmonary hypertension, it causes backup or backflow of the blood into the right ventricle, causing right-sided heart failure. And now it's going to affect the liver, the organs in the GI tract. What else? Causing edema, ascites probably, and also with the other manifestations in venous congestion like JVD as well. Now let's talk about the other manifestations for the patient that may have the mitral insufficiency. Now guys, take note that the insufficiency basically is that problem. There is the improper closure, okay? The function of the leaflet is so impaired that it's not able to fully close when it's supposed to, and it will allow the blood, excuse me, to backflow from the from the left ventricle into the left atrium. Now, for the mitral insufficiency, guys, the person will manifest the systolic murmur, and it's going to be heard in the apical side as well. And again, why is it systolic murmur? Because that swooshing sound or that turbulent blood flow is going to occur when the ventricles are contracting in the systolic phase. Okay, so the backflow of the blood occurs during the systolic phase, and the sound is created because of that turbulent blood flow in an incompetent mitral valve. It's not able to fully close. And so what's going to happen? The blood here will backflow. So we'll take a look into this picture. So with the mitral valve regurgitation, during the systole, it will push the blood from the left ventricle into the aorta or into the systemic circulation. However, when this systole happens, it can also cause the backflow of the blood into the what? Into the left atrium, okay? Let me just check here real quick what's going on with my slide. All right, not quite sure what's going on. Let me just do a quick check. Huh. All right, I think we're good. Yeah, the reason that was that I zoomed out or zoomed in. Okay, so again, for the mitral valve regurgitation or insufficiency, what you will be hearing is a systolic murmur, and this is caused by the turbulent backflow of the blood from the left ventricle into the left atrium when the heart valve is not able to fully close. Okay, now another is the S3 sound. Why is there an S3 sound? This is going to indicate that there is rapid ventricular filling from the volume overload. Okay, rapid filling, or let's just put it this way, rapid ventricular filling. And the reason for that is because of the volume overload. Okay. Why there is volume overload? Remember that in the mitral regurgitation, it's not going to fully eject the blood into the aorta, right? Because there is such leak in the mitral valve. And so a portion of the blood will eventually be going back into the left ventricle. And so it can lead to that S3 sound. It's going to be that extra heart sound because of that rapid ventricular filling from the excess fluid volume in the left ventricle. Now, another manifestation here is the fatigue and weakness. Why is there that? Why are these showing up? Fatigue and weakness, and this is because of the decreased forward cardiac output. Okay, decreased CO. Caused by that regurgitation as well. And the patient will develop the atrial fibrillation. And the reason for that, again, is because the person will develop atrial dilation. Remember about the regurgitation, it can cause that blood to stay into the left atrium, and over time, it will cause that left atrium weaker. It will dilate and eventually will lead into abnormal heart rhythm. Now, there's also that shortness of breath during exertion, and this is because of the reduction in the stroke volume. It's not really going to be able to supply enough blood to the systemic circulation, and so the person will have that rapid breathing as well. They're going to develop some atypical chest pain, wherein there will be some discomfort. It's like an angina type of chest pain here because of the increased myocardial O2 demand. So there is less O2 supply to the heart, but there is an increased oxygen demand. And that is why the person will end up with some chest discomfort, like angina type of pain. All right. Now, aside from that, there will be palpitation rather. The person that may have the chronic mitral regurgitation, this can also lead into the enlargement of the atrium. I'm talking about the left atrium. It will lead to the development of the arrhythmias, atrial fibrillation, and of course, the complication will now cause the atria to stretch, and there will be some kind of a remodeling in that chamber because of the regurgitation, constant regurgitation, I should say. And the person will also suffer from the jugular venous distension. And like I've said, even though the problem started in the left side of the heart, but the complication has already progressed, causing increasing pressure into the pulmonary circulation. It also caused subsequent heart failure to the right side, and that is why they're going to end up with a JVD and the pitting edema. Okay, so Another manifestation here is the paroxysmal nocturnal dyspnea, and the same rationale for that. There is a sudden awakening in the middle of the patient's sleep, and this is because of the pulmonary congestion and the hepatomegaly, which is subsequent to the right-sided heart failure, will also develop. Okay. Now let's move forward to the next valve here that will be diseased. We talked about the mitral, so we're gonna move forward to the aortic valve. So where is that aortic valve? Well, that is exactly located in the pulmonary artery. Now, when there is aortic stenosis, what you're gonna hear in this disorder is that there will be a systolic murmur. It will be audible, turbulent, and the reason for that is that the pulmonary valve is very stenosed. Like I've said earlier, it will restrict the flow of the blood coming from the, hang on a sec. Yeah, from the left ventricle. We're talking about the aorta this time, guys. And so the aortic stenosis, this is going to limit, it will restrict the blood flow coming from the left ventricle. Let me change that to a pen. Whoops, it doesn't let me write. Okay, let me just do it right here. So it will limit the transport of the blood coming from the left ventricle into the atrium because this is stiffened. That passageway, or that gateway, I should say gateway, is not really fully opening, and so there is going to be high resistance that the ventricle has to overcome, and it will lead to that systolic murmur. Again, it will happen during the systolic phase. There will be a shortness of breath on exertion, or dyspnea on exertion, and this is because of the decreased cardiac output. The patient will also manifest the S4 sound, which is basically the fourth abnormal heart sound, and this is associated with the reduction of the ventricular compliance. Okay, and why there is decreased ventricular compliance in the aortic stenosis? Well, what's going to happen here is that the left ventricle is going to do some kind of remodeling because of the increasing pressure that it's facing from the aortic valve. The left ventricle will end up with hypertrophy. Okay, the muscle here will thicken. It will increase in its muscle mass. So let's take a look here real quick about the difference here in the left ventricle compared to the right ventricle. So it's a lot thicker. It's hypertrophied. Now, when there is hypertrophy of the left ventricle, this can also alter its compliance and its relaxation, especially during the diastolic phase. And the left ventricle eventually will become stiffer. Okay? It will become stiffer due to the hypertrophy, and it will now lose its ability to relax. Decreased ability to relax during the diastolic phase. Okay, and so the left ventricle now will be non-compliant, and this is going to cause impairment in the ventricular filling, and that is why we're gonna hear that S4 sound. Okay, what is that S4 sound again? It is produced because of the reduced ventricular compliance. And why there is the reduced ventricular compliance? Well, remember about the ventricular hypertrophy? Yeah, it's growing a lot of the muscle mass. It's like a bodybuilder this time. Now, let's move on to the next manifestation. There's also going to be angina. There will be chest pain. And this is because of the ischemia in the myocardium, because of the increasing oxygen demand by the myocardium, but there is decreased blood supply to the coronary arteries, and so they're going to end up with that angina pectoris. There's going to be syncope on exertion. The person will end up falling after that low oxygen to the brain. There's also going to be fatigue and also generalized tiredness. And the reason for that is the decrease in cardiac output. The patient will also end up with orthopnea. They're going to be breathlessness. There will be breathlessness when they're laying flat in bed, and that is because of the pulmonary congestion. There's going to be paroxysmal nocturnal dyspnea as well. This is associated with the pulmonary edema. And another is the narrowed pulse pressure. There is going to be a reduced difference between the systolic and the diastolic blood pressure because of the reduced stroke volume. Okay. Remember, guys, what that stroke volume is? Do you still remember that? So the stroke volume basically is that total amount of blood that is pumped by the heart's left ventricle when it's contracting. Okay, so it's not by the minute, but it's the amount of blood that the left ventricle is producing per contraction. Okay, so the volume here normally for the stroke volume is 70 to 100 mLs per beat or per contraction. Okay, and so with the aortic stenosis, this is going to lead to a reduction in the pulse pressure. It simply means that there is a reduced difference. So for example, the blood pressure of the patient probably will end up with 100/90. Supposedly, our pulse pressure will be, let's say, 40 to 60 mmHg. That is the usual normal range. But when there is narrowing of the pulse pressure, so there is that very little difference here. It's less than 40 mmHg between the two. And so the reason for that, again, it's because there is a reduction in the stroke volume, right? Now, what else do we need to expect in this patient with left or the aortic stenosis? Do we have any more? Let me check. All right. We're going to need to move forward with the aortic insufficiency or the aortic regurgitation. So what is this basically? Well, this problem is going to also lead to some weird assessment findings. There will be diastolic murmur. Like, again, this is going to occur during the relaxation phase. That backflow, that turbulent backflow will occur when the ventricles are relaxing. All right. Now, the person will also manifest some sinus tachycardia, and this is a compensatory mechanism of the decreased cardiac output. There's also going to be exertional dyspnea, and of course, any kind of even simple activity can be too much for the patient. And the reason for that is because of the decreased cardiac output as well. There will be orthopnea. The patient will not be able to really tolerate breathing when they are flat in bed. They need to sit upright in order to catch their breath. There's also going to be palpitations. And this is because of that irregular heartbeats as well. There is going to be fatigue. They will get so tired easily, exhausted. There's going to be nocturnal dyspnea, nocturnal angina rather. There's also diaphoresis. And it's because of the increasing myocardial demand. Myocardial demand for oxygen. And the body is not able to meet that need. All right. So the demand is higher, but the supply is low. Now, the person will end up with widening pulse pressure here. So this is different from the aortic stenosis. The pulse pressure here is widened. There is a huge gap between the systolic and the diastolic blood pressure. And why there is that widening of pulse pressure? Well, the reason for that, it's because of the regurgitation, okay? The volume that has flowed back into the left ventricle will also eventually get pumped back into the systemic circulation through the aorta, okay? And so they're going to end up with that widening pulse pressure. The patient will also end up with a bounding arterial pulse. This is what we call as the Corrigan's arterial pulse. Are you familiar with this one, guys? So the Corrigan's pulse is basically our bounding arterial pulse. Excuse me. Bounding arterial pulse. And the reason for that is the increased stroke volume and also the widening of the pulse pressure. Widened pulse pressure. So what causes the Corrigan's pulse? This is caused by the increasing stroke volume and the widening of the pulse pressure. Now, what is really going on in this scenario? There is, during the diastole or diastole, the blood from both the left atrium and the regurgitant flow. It will flow the left ventricle, okay? So how is this happening? So during the relaxation phase, let me just write here, relaxation or diastole. When the heart is in a resting mode, okay? So what's going on here? The blood coming from the left atrium will enter into the left ventricle, okay? Now, along with that, there is that increasing amount of blood, because it's not just the blood that was supposed to be pushed right by the left atrium, but also with that residual volume, there is increasing volume being transported by the left atrium to the left ventricle. So there is now there is now an increasing amount of blood that will fill up this chamber. Okay, this will fill up this chamber, and this is going to increase the amount of blood. This is what we call as the increased end diastolic volume. Increased. Let me just rewrite that. I don't like my handwriting anymore. Increased end diastolic volume. Okay. Eraser. So again, there is massive filling of blood into the left atrium, coming from the left ventricle rather, coming from the left atrium, and this is what we call as increased end diastolic volume, or simply known as the preload. And what it can do to the heart, it can lead to that bounding pulse, arterial pulse, known as the Corrigan's pulse. All right, please don't forget that. Now let's move on to the next manifestation in the aortic insufficiency. This is going to be the elevation of the systolic and the diastolic pressure. And this is reflecting the inefficiency of the left ventricular ejection, okay? Why is inefficiency? Remember, guys, that the aortic valve right here is restricting aorta, or the aortic valve rather. The aortic valve is restricting blood flow from the left ventricle. Okay. So again, this will allow collection of the blood. It's not going to fully pump the blood into the systemic circulation because of the stiff, I mean, not stiff, but it's actually going to allow that blood to go back right here. The aortic valve is not going to fully close. So the blood here will eventually go back into the left ventricle. Okay. Now let's move forward to the next section here about the diagnostic tests in valvular heart disease. There are so many. One of those is the chest x-ray, and this is going to be one of the early tests that you will be seeing in this patient. And what you're going to see is there will be enlargement of the heart, cardiomegaly, and because of the what? Congestion, chronic congestion into the left ventricle, so you will see some dilation of the heart chambers. So it will be dependent onto what valve is causing the problem, right? So if there is going to be aortic stenosis, or let's say mitral valve, a regurgitation, or mitral valve, yes, it can lead into the, what do you call this, enlargement of the left ventricle. Okay, now for the 12-lead EKG, guys, what can be determined here is that there will be detection of irregular heart rhythm, atrial fibrillation, which is a very common issue. And with echocardiogram, which is another diagnostic test, this can detect if the valve isn't opening or closing properly. And it will also detect if there is leaking or regurgitation through a valve, or let's say there is stenosis. And also it can give us better picture or images of the heart structure and also the function. And there's also another variety here. We have the transesophageal echocardiography. Have you heard about the TEE, which is much more invasive procedure? Transesophageal echocardiography. This is going to require the patient to sign a consent. This is an invasive procedure. They're going to be, and they're going to need to have that consent to be signed. Make sure that they're NPO before the procedure, about 8 hours, because the approach here is in an endoscopic procedure. Okay, this is going to allow the passage of the tube, that probe that will pass through the esophagus, okay, or to the throat. Another is the stress test. This is also going to be ordered by the medical provider in order to check the person's ability or the heart function, in order to check its tolerance to any kind of stressful activity, and also to check if the patient is going to develop symptoms like chest pain or shortness of breath during an exercise, okay? Which is not typically going to show up during the rest period, but with a stress test, this will really cause the extra pressure into the heart, get more of like a increase oxygen demand. So this will test really if the heart is able to overcome the extra stress. Now there's also the nuclear or radionuclide studies, and this is going to involve the injection of like a radioactive substance into the IV, and this will also help with checking the blood flow to the heart. It will detect any reduction in the blood flow or could be damage into the heart muscle. Now, another is the angiography. Excuse me. The angiography is that, what do you call this? It's an imaging study, of course, with the injection of that contrast media into the bloodstream in order to allow better visualization through the heart's arteries. And also, it can identify the narrowing or the blockages that may be affecting the heart valve function. Please, which one is so significant? Is systolic is high, or systolic is normal, or let me just go back into that slide. Just want to make sure we are on that same page. So your question is, which one is so significant? If systolic is high and the diastolic is normal, or if systolic is normal and the diastolic is high? Well, the one that you're going to prioritize here, AJ-ICTV, is that when it's going to compromise the cardiac output, okay? When it's going to really cause a compromise into the blood supply to the system. Let me go back where that exactly. Elevated systolic and diminished diastolic pressure, and I think you're talking about the aortic insufficiency. Yeah. Okay. And so the The real problem here, guys, is that when there is an elevation of the systolic, or let's say diminishing diastolic pressure, both are abnormal, right? What you're going to have to be worried about here is the compromise in the blood supply. The cardiac output really is going to be the end problem here. Okay, either systolic elevation, or let's say the pressure is elevated during the contraction, but still our issue here is the aortic insufficiency. There is that weakening of that valve here. And so again, the forward flow of the blood coming from the left ventricle into the aorta or into the systemic circulation is still diminished. Okay, no matter what, there is increasing pressure, but the real problem here is basically the ability of the left ventricle to really effectively pump the blood. That is really the main problem here, which will eventually lead to the decreased cardiac output. Okay, so it's the ejection part. Okay, it will not really produce enough blood to supply the body because of that aortic insufficiency. It will allow the blood going back into the left ventricle. And remember, guys, this is going to get tired eventually. This will dilate. There will be left ventricular enlargement. So the more that the person will end up with the decreased ejection fraction, left-sided heart failure, we should say. Okay, so I hope that helped. Now let's move forward here. We are talking about the, which one was that? Radionuclide study and geography. I think we did already. What else? Geography. Yeah, we did that. Moving forward, we are going to talk about the different nursing actions here. So I'm just going to give you an overview, the general nursing actions this time. And so one of those general nursing actions is to monitor the parent's current weight. This is very important because most of our patients here are developing the heart failure. It could be the right-sided or the left-sided heart failure. And we're going to talk about the, this pertains to the increasing weight caused by the retention of fluid. Let's say, for example, if this is related to a right-sided heart failure. So definitely we need to make sure we are checking into the daily weight to see if there is a significant accumulation of fluid into the system. Now, we're also going to need to report that significant weight. So for example, if it's greater than 2.2 pounds per day, you have to make sure that this is relayed to the medical provider, because this is really a sign that the heart failure is worsening. Now, another is cardiac rhythm assessment. This is to make sure we are checking the patient for any irregular rhythm. If they become bradycardic, we need to assess for any murmurs. Or let's say atrial fibrillation, maybe with rapid ventricular response. We need to act on this one. We want to make sure that our patient will be able to maintain some sort of safe hemodynamics, even though we already know that they have decreased cardiac output. But we want to make sure that at least they will still maintain that oxygenation to the body, despite that they have already developed that complication. Now, we're going to talk more about the different specific nursing interventions in the next few slides. Now, we're also going to talk about the oxygen and the medication administration. So there's so many pharmacological agents that will be involved here. As far as like with the hypoxemia, we're going to have to provide the appropriate amount of O2, the concentration to the patient as ordered. We have to make sure that we are monitoring constantly the patient's O2 saturation during the critical phase. The person will probably be needing different medications such as diuretics, especially if they're having some pulmonary edema, or let's say vasodilators in order to decrease the afterload. or to decrease the vascular resistance, or maybe to give them some medications like beta blockers in order to reduce the heart rate if they have tachycardia, right? So with the medications that I'm talking about here, we're going to treat the patient symptomatically, okay? Now, another is that we're going to have to check for the patient's hemodynamic status. We want to make sure that we are maintaining safe ranges in their blood pressure, their heart rate, and we want to make sure that we are assessing the effectiveness of the treatment as well, or let's say to detect any worsening of their heart function. Now, aside from the hemodynamic monitoring, we're going to have to implement fluid and sodium restrictions, which is really essential in preventing fluid overload and also to decrease the chances of exacerbating the manifestations. All right. Now we're going to talk about the specifics here as far as, there you go. Energy conservation is also important here, guys. We want to make sure that we are reducing any extra physical activity in our patient. We want to make sure that they are getting enough amount of rest periods, because when they're going to get fatigued, this will increase the oxygen demand. We don't want that. We don't want to cause more demand of oxygen. We want to make sure that their heart is going to in a chill mode, okay? We want to make sure that they're going to maintain that minimum tissue perfusion. Now, it will also reduce the strain in the heart if they're going to get enough rest periods. Now, talking about the different medication therapy here, one of those medications that will be ordered by the medical provider will be the diuretics, right? And we know already that this can be used to treat heart failure, to remove excess fluids in the vascular system, or it could be to decrease the amount of fluid in the lungs or like the alveoli because of the pulmonary edema. And so this will include those loop diuretics like Lasix. We also have the thiazide diuretics and also the potassium sparing diuretic. So during the acute phase, if the person really needs rapid removal of the excess fluid in the heart or in the lungs, we're going to expect the delivery of an IV Lasix or furosemide to allow rapid removal of the excess fluid in the system. But for like maintenance doses, you're going to be expecting here oral medications like thiazide or oral loop diuretics, or maybe potassium sparing diuretics, because they probably have a history of hypokalemia. So we really want to conserve the patient's potassium in order to prevent complications. Now, when we are administering the diuretic, make sure that you are administering this slowly, especially if you are giving this IV. Okay, slow IV push. And you're going to do that in 1 to 2 minutes. And the reason? It can lead to hypotension. We want to make sure that it cannot drop the blood pressure rapidly. Okay, we don't want that. So make sure you do the push slow at 1 to 2 minutes. Now, remember about the onset of the drug action. It's going to take about 5 to 10 minutes for the medication to work. Within 30 minutes, the person will end up diuresing lots and lots of urine. So probably within 15 to 20 minutes, they're going to fill that urinary bag already. So you're going to watch out for the urinary output and also the blood pressure. Okay, so that's my tip for you. Make sure that you check the blood pressure. You're also going to check the urine output at this time. Now, another thing that you're going to need to do, aside from the diuretic, is to expect the administration of the afterload reducing agents. So what are these medications? Afterload reducing agents. So basically, what we are looking for here are those known vasodilators to decrease the systemic vascular resistance, to decrease the workload of the left ventricle against that high pressure. So what are those medications? Well, this includes the ACE-I, or the ACE inhibitor. So what is that? This comprises the lisinopril, captopril, enalapril, those pril medications. And I'm not going to go back into the drug action again. I've repeatedly mentioned those items before. So let me just put here the suffix, pril. These are the ACE inhibitors. We also have the ARBs, or the angiotensin receptor blockers, the sartans, valsartans, losartan, candesartan. We also have the beta blockers, the OLOs, okay, metoprolol, carvedilol, which is going to control the heart rate of the patient if they're going to end up with tachycardia. Not intended really for the hypertension this time if they are having decreased cardiac output, right? And so the beta blockers will be used to treat the tachycardia this time. Calcium channel blockers will also be helpful in treating the patient. These are your felodipine, nifedipine, the amlodipine. So the PIN medications, calcium channel blockers. These are known to what? Relax the smooth muscles of the heart. It will decrease the heart rate. And another action for this is it will decrease the blood pressure as well. It will decrease the contractility of the muscle layer of the artery, okay? Now, another medications that we will be encountering here are those vasodilators, such as the hydralazine, okay? Of course, this is going to be given in such a case when there is hypertension, okay? Not really about the reduction in the cardiac output. So we're talking about the general medications intended for the valvular heart disease. These are not the specific medication to the aortic, whatever. It's like a general medical or general pharmacological intervention. So what else do we need to expect here? There's going to be administration of the inotropic. So what are these inotropic agents? An example here is the digoxin. And the reason for that, it's because of the right-sided heart failure, or possibly the left-sided heart failure. We are going to enhance the contractility of the myocardium in order to achieve that safe cardiac output, okay? And so you might be asking the NCLEX regarding how to teach the patient when they are self-administering the medication at home. What will be your patient teaching? So make sure that you instruct them to count their pulse for 1 minute. Count pulse for 1 full minute. All right? Make sure that they do that. Not to do the 15 seconds and multiply by 4. No, that would not be ideal, guys. Their heart rate is probably irregular. So we really want them to do the full minute checking, okay, before they take the digoxin. As we know that the digoxin can lead to decreased heart rate. So we want to make sure that they're not bradycardic before they take the medication. So what we're going to also include in the teaching is to hold the dose. Hold the dose if the heart rate is what? Less than 60 beats per minute. And this is something that you can apply also in the inpatient setting. You have to hold the medication. You're going to have to notify the medical provider that you're not able to give the medication right now because the heart rate is slow. It's bradycardic. We don't want to cause any more slowing of the patient's heart rate. Another is to make sure that they are taking the drug the same time each day. Okay? Patient teaching. Same time each day. Each day. Let me correct that. And the reason for that regular schedule, okay, is to make sure that we are allowing the therapeutic levels of the medication to be consistent in their bloodstream. Okay, I know that this is a daily medication, but we want to make sure that they're consistent in taking their drug in order to allow that therapeutic level of the digoxin. Okay, now, looks like we're back to this one, education. Oh yeah, we are talking about the digoxin. Here we go. Now, we're also going to include in the teaching that they should not be taking the digoxin at the same time with the antacids. And the reason for that, it's going to affect the absorption of the medication. So make sure that we are going to tell them to separate the two medications by at least 2 hours. Okay? So the patient should not be taking the digoxin at the same time as the antacids. Make sure that they're going to separate the two medications at least 2 hours to prevent absorption issue by the digoxin. Now, another teaching here is for the patient to report signs of dig toxicity. Digoxin toxicity. So what are those signs? Early would be confusion. That's one. There will be anorexia. Confusion, anorexia, nausea, vomiting, and also diarrhea. There's also going to be some visual disturbances. There will be halos around light, some discoloration in their visual field, greenish discoloration. But most often, guys, these are the early manifestation: confusion, anorexia, nausea, vomiting, diarrhea. Okay. Now, another medication that you will be expecting to administer is the anticoagulant. Why there is going to be anticoagulation? Well, the reason for that is the patient will be needing blood thinning. Blood thinning is needed when they receive a mechanical valve as a replacement. Blood thinners will be needed if they have received the mechanical valve replacement. Let's say, for example, mitral valve replacement, or let's say because they have a atrial fibrillation. That's another condition that will call for the anticoagulation, because if we are not going to thin their blood, then eventually they're going to throw a clot. It can lead to strokes, thromboembolic stroke. And also because there is that left ventricular dysfunction, heart failure, right? Left ventricular heart failure. Remember about the stasis of the blood in the left ventricle and also pooling of the blood in the left atrium. When there is prolongation of the blood stasis inside those chambers, it can lead to blood clots. And so we want to make sure that the patient will be compliant in taking their blood thinners in order to prevent the complications. Okay. Now let's move forward into the surgical management. We're almost through here with the concept. We will be going through the questions in a minute. Now for the surgical management here, we're going to expect one of these management, which is the percutaneous balloon valvuloplasty. So this is a procedure that can open the aortic and the mitral valves affected by the stenosis. Again, the percutaneous balloon valvuloplasty this is going to open the aortic or the mitral valve affected by the stenosis. Intended for aortic and mitral stenosis. So what is involved here? There is a catheter insertion. And this is going to be inserted into the femoral artery, and it will be advanced into the heart, just similar to the cardiac catheterization. And there is going to be inflation of the balloon at the stenotic lesion. Okay, so the approach here will be insertion of catheter into the femoral artery, and eventually into the heart. Now, what's going to happen? This will now involve inflation of a balloon. So where is the balloon going to be situated at? It will be advanced into the stenosed valve. And this is going to open up that fused commissures in order to allow movement of those leaflets. Okay, so it has that similar kind of effect, just similar to the percutaneous transluminal angioplasty. It will open up. It will now allow movement of the valve, either the aortic valve or the, what do you call this, mitral valve. Now, what are we going to do here as nurses post-op for the percutaneous balloon valvuloplasty? There's many things that we will be able to do. Part of the care here is to make sure we are doing our routine, what? Post-op check, post-op assessments. We're going to have to check their vital signs. We're going to have to monitor their cardiac rhythm. Another is that we're going to have to check their neurostatus, because we want to capture if there is compromise to the brain supply, the blood supply. And this is very important, guys, that we are also checking onto signs of any complications. So we're going to have to check for any bleeding to the site, the insertion site, I should say. Check for any arrhythmias. We're also going to need to check for any neurological deficits. Okay, check for neuro deficits. So this simply means that there is now poor blood supply to the brain. Now, another thing that we need to go to do for the post-op phase after they undergo the percutaneous balloon valvuloplasty, we're going to have to check the site for any signs of hematoma. Aside from bleeding, we're going to check for hematoma. I mean, this is also bleeding. It's just underneath the skin, but it's like the bruising, ecchymosis rather. We've got to make sure that we are monitoring that from time to time. Or let's say signs of infection. All right. Now, another thing that we need to do for this patient post-op after the percutaneous balloon valvuloplasty, remember that we are giving them some diuretics, right? Because of the fluid volume excess. So you're going to anticipate here some imbalances in their electrolyte count. So what are you going to do here? Well, we will be checking the patient's daily lab result. Check lab reports. And I'm talking about daily lab reports. So we are talking about electrolyte count, especially for those getting the diuretics, potassium, magnesium. These are the electrolytes that are commonly lost in the body when the patient takes diuretics, especially Lasix. Telling you guys right now. This is kind of annoying because we're actually treating the patient because of the fluid volume overload. We are giving them the diuretic, but With that diuretic, it can also lead to hypokalemia. It can cause hypomagnesemia. And when this happens, it can lead to a lot of arrhythmias. So we want to make sure that we are following into the patient's electrolytes when they are taking diuretics. Please take note of that, okay? Never miss that. When you are giving any diuretic to the patient, always worry about the electrolyte counts, especially the potassium and the magnesium. Yeah, we can also worry about the calcium, the sodium, but most often it will be the potassium and the magnesium which will be severely affected. It can do a lot of problems into the heart function. Now, also, during the post-op, we need to make sure that we are checking eyes and nose. Make sure that we are checking the patient's kidney function as well. Make sure that it's close to what they are taking in. Because if there is more in than out, then that simply means that there is worsening in the patient's condition. There is decreased blood flow to the kidneys. Now, another nursing intervention that we need to implement in this patient post procedure, let me clear my notes. Here you go. Will be the, hang on a sec. The valve replacement here is another surgical procedure, which is going to probably include the use of a mechanical valve, or maybe the person will probably need a cadaver valve. Okay, let me just put it right here. So it could be mechanical. Okay, it could really require the patient to take the anticoagulant. Guys, this is very important. Take note of this. If the patient ends up with getting a mechanical valve, make sure that the patient is taking the anticoagulant, or else this will be clotted off. Yeah, it will clog. It will no longer work. And so you make sure that the patient is consistently taking their medication. They need to have periodic testing for their INR-PT if they're using the warfarin or Coumadin. Okay. Another thing is that when the patient has a mechanical valve replacement or mechanical graft, let's say, for example, like xenografts, what is that? Or let's say allografts. This is actually taken, xenografts is going to be sourced from different species. Let's say porcine type of graft. And so what you're going to expect here is that the graft itself will undergo some kind of like cleansing in order to remove those antigens. Okay, so I repeat, the use of the xenograft or like different species, let's say coming from a pork, the patient will get that graft that has already been pre-washed. It simply means that the graft has already been removed of any of those antigens to prevent any rejection of that graft. Okay, so you will rarely, or you will not really see a patient with a xenograft taking any anti-rejection medication. And the reason for that is because it's already been pre-washed, it's already pre-treated. They're removing the antigen already in order to prevent any rejection. Now for the allografts, so this is what we refer to as the bioprosthetic, or the graft coming from the cadaver. Okay, and so the person here will rarely get any anti-rejection medication. And the same reason for the xenograft, the cadaver valve has already been treated as well. They have already washed or already removed those antigens that will decrease the incidence of rejection. Okay, so again, the patient will not be expected to take lifelong anti-rejection medications. So some of them will be taking anti-rejection medications for a short while, but not expected to be taken in their lifetime. Now we're also gonna have the autographs, wherein the person will be getting a section of their valve from their own blood vessels, right? Another is that we have to really know about what to do when the patient receives any of the mechanical valve or grafts. So what are we going to do here? Nursing interventions or nursing actions. All right. So in the immediate post-op, we're going to have to monitor vitals, of course. They will be more frequent during the post-op phase. We really want to capture or detect those subtle changes in their vital signs. We're also going to check for bleeding, any arrhythmias, signs of fluid overload. Okay. Check for any arrhythmias. We're also going to check for any bleeding from the incision site. We're also going to check for fluid volume overload. All right. Now, part of the care here as well is to make sure we are assessing the surgical site. We want to make sure that we are keeping an eye onto any signs of infection, hematoma, if there's any excess drainage, or let's say discoloration of the surrounding skin, redness. Those are signs of infection, right? Another is to intervene for their pain. Pain control is important. Why? If their pain is not controlled, then they're not going to be able to participate in the coughing and deep breathing exercises. So we want to make sure that their pain level is controlled so they can do the coughing and deep breathing exercise, and also to make sure they use the incentive spirometer. IS, we know that post-op complications can really set in even during the first 24-hour period. They can develop hypostatic pneumonia, so we don't want that. So make sure we are giving them enough pain control in order that they can do the cough deep breathing exercises. Another is to administer the anticoagulants, especially if they are using the mechanical valve. Let me erase this. Anticoagulation. So what we're going to do here, anticoagulation and monitoring, especially if it involves the use of the warfarin. We need to keep an eye on the PTINR in order to maintain that safe therapeutic range in order to prevent bleeding risk. So we want to make sure that the patient is not having way too much of the Coumadin or very low level of the Coumadin. We want to make sure that they are on that safe range. Okay. Now, another is to monitor for any signs of endocarditis. What are these things? Well, we want to make sure that our patient's temperature is checked routinely, okay, or frequently. As if there's any slight changes or any increments, we want to make sure that we are keeping an eye on that one. Infection can set in, which will eventually cause problem to the new valve as well. Okay, we need to keep an eye for the patient's temperature level, signs of drainage from the insertion site. Those are going to be crucial. All righty, what are we going to do next here? We're going to have to do the exercises. So the first question for you guys is, when auscultating to a client's heart, the nurse hears a murmur at the second intercostal space on the left side near the sternum. Which heart valve is likely affected? Question 1, When auscultating to a client's heart, the nurse hears a murmur at the second intercostal space on the left side near the sternum. Which heart valve is likely affected? Is it A, aortic, B, pulmonic, C, or B, mitral, rather, C, pulmonic, and D, tricuspid? Again, when auscultating to a client's heart, the nurse hears a murmur at the second intercostal space on the left side near the sternum. Which heart valve is likely affected? Is it A, aortic, B, mitral, C, pulmonic, D, tricuspid? The correct answer here for this test question is letter C. That is the pulmonic valve. Okay. Okay, so the pulmonic valve will be detected at the second left intercostal space next to the sternum. If you had answered letter A, aortic valve, that is incorrect because this is supposed to be heard at the second intercostal space to the right of the sternum. Okay, so this is what? Going to be heard in second ICS, but right side of the sternum. What about the mitral valve? It is also incorrect because the mitral valve abnormalities are heard in the fifth intercostal space in the midclavicular line. Okay, where's my mouse? Mitral valve abnormalities are supposed to be heard at the fifth intercostal space to fifth intercostal space in the midclavicular line. All right. Now for letter D, tricuspid, that is incorrect because this is supposed to be heard in the between the third and fourth ICS along the sternal border. Okay. So please don't forget the anatomical positions of the heart sounds in order that you can identify the affected heart valve. All right, question number 2. A nurse is examining the medical history of a client being assessed for the valvular heart disease. Which of the following are risk factors? Select all that apply. Again, a nurse is examining the medical history of a client being assessed for the valvular heart disease. Which of the following are risk factors? Select all that apply. Is it A, had atrial septal defect surgery at age 2? B, contracted measles during childhood? C, hypertension for 5 years? D, gained 10 pounds in the past year? And E, presenting with a diastolic murmur. So it's asking you guys which of the following are risk factors for the valvular heart disease. This is select all that apply. Okay. So the correct answers here are the following. We have letters A, C, and E. So that would be had atrial septal defect surgery at age 2. There's also C, hypertension for 5 years, and letter E, presenting with a diastolic murmur. Now, for letter A, what's the rationale for that one? When the person has a history of congenital heart defect, let's say an ASD, if they have that condition, of course, they're going to end up with that valvular heart disease, okay? If you answered letter B, contracted measles during childhood, this is not a risk factor to developing the heart valve problem. However, during childhood, what is common is the streptococcal infection. All right? Or the rheumatic heart disease, RHD. D. These are the known infections that can lead to valvular heart disease in later life. Now, if the person had if you answered letter C, hypertension for 5 years, that's already chronic, right? And with this problem, hypertension, this is going to cause the heart problem, the valvular heart disease, as this is going to also lead to the weakening, the ventricle, systemic vascular resistance is part of it. It will lead into the aortic, the backflowing of the blood from the aorta into the left ventricle as well. Okay, the long-term hypertension. Now, if you had answered letter D, gained 10 pounds in the past year, would that really mean anything? Well, no, it doesn't. If it's going to be a sudden weight gain, then that would be significant. It will indicate that the patient may be developing fluid retention. But again, gaining weight for 10 pounds weight gain in the past year, that would not be significant for this scenario. Now for letter E, presenting with a diastolic murmur, this basically suggests that there is turbulent blood flow that is going to be present in the valvular heart disease. Okay. Now let's move forward to number 3. An older client is scheduled for a percutaneous balloon valvuloplasty, and the patient wants to know what this procedure will achieve. What should the nurse say? Again, an older client is scheduled for a percutaneous balloon valvuloplasty. The family wants to know what this procedure will achieve. What should the nurse say? Is it A, it will improve blood flow in the coronary arteries? B, it will help with daily activities? C, it will extend the life expectancy with this valve condition? Or D, it will reverse the valve damage? Valvuloplasty. Remember about that procedure, that it will involve the introduction or insertion of that catheter and also that balloon into that area where the valve has become stiff. It will open up that valve. So what would be the rationale, or what would be the best answer by the nurse? We're talking about the valve here, guys. It's not about the coronary arteries. We're not talking about angioplasty. We're talking about valvuloplasty. Okay? Percutaneous balloon valvuloplasty. Heart valves. Remember, it involves insertion of the catheter. It will be advanced into the heart. It will be positioned into that valve that is stiff, the Stenosis type of valve. So what would be the correct answer? Okay. The valvuloplasty is not really a permanent treatment, guys. Okay. It's not. And so it is going to be considered like a palliative kind of procedure. So the correct answer here is going to be letter B. Why? It's kind of subtle, right? It will help with daily activities, kind of hidden. The reason behind that, it's that answer, because the valvuloplasty is going to enhance the blood flow through the valve, and it will improve the symptoms or reduce the symptoms. Again, this is targeted to what? The valvuloplasty is targeted to treat aortic stenosis and also the mitral stenosis. Remember? Mitral stenosis and aortic stenosis. And remember that the patient will have a reduced ejection fraction. The reason for that is because of the increased resistance in the pulmonary, the aortic artery. Okay. The aortic artery that's supposed to receive blood from the left ventricle. Remember that stenosis right here? And so that valvuloplasty will be introduced into the artery. It will be going to be situated right here. That balloon will open up that stenosed valve. Okay? It will open it up. It will reduce the valvular disease manifestations such as the decreased cardiac output, regurgitation. Again, this is not going to be really curative. It will allow better performance of daily activities. It will help with the daily activity. So, meaning the person will be able to tolerate some more daily activities, like the routine stuff that they were supposed to do in the past. Okay. If you had answered letter A, it will improve blood flow in the coronary arteries. Remember that we are not talking about the insertion of the catheter into the coronary arteries, right? We're not. We are dealing with the valve, not our coronary arteries. If you answered letter C, it will extend the life expectancy. Excuse me. This cough has been bothering for more than a week, but it's worse yesterday and today. So please bear with me. Letter C, it will extend the life expectancy with this valve condition. Yeah, it can improve, but not necessarily prolong the life expectancy. It can improve, but not prolong. Not extend the expectancy or life expectancy makes this statement wrong. Okay? This is wrong. This is wrong. What about letter D? The procedure will reverse the valve damage. No, it doesn't. It does not reverse the existing valve damage. It only helps improve the valve function. It's not going to be permanent. It's not going to cure the patient of the aortic stenosis or the mitral stenosis. All right. Now let's move forward to the next question. Question 4. For a patient with infective endocarditis and reduced, for a patient with infective endocarditis and reduced cardiac output due to the valvular insufficiency, which finding supports the diagnosis? Remember that infective endocarditis can also lead to the valvular heart disease, right? The bacteria infecting or the invading microorganism can attack the heart valve. And so the question here is, which finding supports this diagnosis? We're talking about infective endocarditis. Is it A, fever, chills, and sweating? Or is it B, urine output less than 30 mL per hour? Or C, small red or purple spots on the mouth and eyes? Or is it D, increase in heart rate by 15 beats per minute with activity? So which of the following manifestations can support infective endocarditis leading to valvular insufficiency? Infective endocarditis. Guys, please reread the question carefully. Reread the question. For a client with infective endocarditis and reduced cardiac output due to the valvular insufficiency, which finding supports this diagnosis? Guys, be careful. Be careful. Be careful in selecting your answer right now. For a patient with infective endocarditis and reduced cardiac output. Okay. Well, you might get surprised here because you had answered, most of you guys answered letter A. All right, no worries. The correct answer for this is the letter B. Urine output less than 30 mLs per hour. I know this is the end result of the problem. The valvular heart disease is complicating into the reduction of the cardiac output, reduced blood pressure, reduced perfusion to the kidneys. I know that infective endocarditis is an infection, right? Fever, chills, sweating are the common manifestations of infective endocarditis. But these do not directly, they are not directly caused by the reduced cardiac output. Please take note of that. So you have two things to watch out for here, guys. The infective endocarditis, which is really the causative, or the cause right here, okay? And the other one, which is the reduced cardiac output. So do you think that the fever, chills, and sweating can be the manifestation overall, from the two? I doubt. So I would say that this is partially correct, but not fully correct. Because what we're actually looking for here is the end result of the problem. The infection first, leading to a valvular heart problem, causing cardiac output decrease, leading to low blood pressure. It's going to impair the kidney perfusion. And so we are looking for the letter B instead, okay? Now, if you had answered letter C, small red spots, these are your petechiae, right? So these are manifestations of infective endocarditis. Manifestation of IE, but not necessarily manifestations of a reduced cardiac output. All right? Only about IE. Now, let's take a look on letter D. Increase in heart rate by 15 beats per minute with activity. Well, a slight increase is actually considered as normal, okay? So we're gonna eliminate letter D as well. So we are left with letter B. Urinary output less than 30 mLs per hour, okay? I know, it's kind of tricky here that we have the infective endocarditis, but here we also have the reduced cardiac output. Now, moving on to question 5. A 23-year-old patient with mitral valve prolapse without regurgitation is being discharged which statement indicates, let me reread that question. A 23-year-old with mitral valve prolapse without regurgitation is being discharged. Which statement indicates correct understanding of discharge instructions? Is it A, I need antibiotics before dental visits? B, I should avoid physical activity to prevent stress on my heart? C, I need to avoid over-the-counter stimulants? And D, I should take aspirin daily to prevent valve clots. Take your pick. A 23-year-old with mitral valve prolapse without regurgitation is being discharged. Which statement indicates correct understanding of discharge instructions? Is it A, I need antibiotics before dental visits? B, I should avoid physical activity to prevent stress on my heart? C, I need to avoid over-the-counter stimulants? And D, I should take aspirin daily to prevent valve clots. Guys, our patient with a case of MVP without regurgitation. Without regurgitation. So we are looking for that statement that indicates correct understanding of the discharge instructions. All right, waiting for your answers right now. Hmm. Okay. I'm seeing a lot of C's right now. You are correct, guys. The answer here is letter C. I need to avoid OTC stimulants. Why? The reason for that is because, oh my God, I'm just about to sneeze. Excuse me. Trying to avoid it. So the answer is letter C. The reason for that is because patients with MVP should avoid the stimulants like caffeine or decongestants. So avoid caffeine, decongestants, like those simple cold medicines, because they can exacerbate the symptoms like manifest the palpitations. Okay, this will cause palpitations, arrhythmias. Yeah, and look at the word here, over-the-counter stimulants. And remember that what it can do to the heart, it can actually cause some more work for the heart, right? It's going to add more strain into the heart muscle. It will now exacerbate the manifestations of the mitral valve prolapse. So this is the answer that we need. Why not letter A? Why is letter A wrong here? The reason that A is wrong, it's because the person or the patient will not need any antibiotic before they go to a dental visit. Okay, especially if there is no regurgitation. Okay, they're only gonna need the antibiotics if there is regurgitation. Our case here states that the patient does not have any mitral valve regurgitation. So again, the antibiotic prophylaxis is only intended for dental procedures that may have, for those patients that has mitral valve regurgitation, or maybe if they have a history of infective endocarditis. Since the dental procedure is invasive, it could potentially cause infection. And so we want to make sure that they're taking the antibiotic only if they have regurgitation, not without. Okay, so that is the word that we need to have it in this option. Now, letter C, or letter B rather, I should avoid physical activity to prevent stress on my heart. I should avoid physical activity in order to prevent stress on my heart. That is erroneous, guys, because the patient should not be limited, okay, in doing any kind of physical activity. I mean, they can do the regular ADLs, especially that they don't have any regurgitation. There is no regurgitation, so there's no restriction in their physical activity. So they can still proceed with the physical exercise that would be beneficial for them. Okay. Now, what about letter D? I should take aspirin daily to prevent valve clots. Well, the aspirin is not going to be useful. It's not going to be recommended for this patient, especially that there is no regurgitation. And this is only reserved to patients, again, for regurgitation, and if they have history or if they have a risk in developing thromboembolic events. Or that tendency to develop blood clots. So they will be using the aspirin, but not in this patient that has no regurgitation at all. Okay, So we are left with letter C as our correct answer. All right, let's move on to the next question, guys. Number 6, for a patient with aortic stenosis experiencing chest pain due to reduced coronary blood flow, which nursing action is appropriate? Is it A, encourage rest to lower heart oxygen demand? B, explain the need for blood thinners? C, advise using sublingual nitroglycerin for pain? And D, raise the head of the bed to 60 degrees. The question states, for a client with aortic stenosis experiencing chest pain due to reduced coronary blood flow, which nursing action is appropriate? A, encourage rest to lower heart oxygen demand. B, explain the need for blood thinners. C, advise using sublingual nitroglycerin for pain. And D, raise the head of the bed to 60 degrees. Our scenario states patient has aortic stenosis with chest pain because of the decreased coronary blood flow. What is your answer here? Well, aortic stenosis. So, our main issue here is the stenosed aortic valve. It's not really the coronary artery. There is no problem. There is no problem in the coronary arteries according to the scenario here. There's no blockage, no clots, nothing whatsoever, nothing. Okay, so the problem here is basically the aorta. So, if they are experiencing chest pain, all right, the chest pain can be relieved by what? It can be relieved by letter A, encourage rest to lower heart oxygen demand. Okay, so it actually will be a simple rest. It will decrease the oxygen demand. That is letter A. Okay, it will alleviate the chest pain. The chest pain will go away once the patient will be rested. Okay, if you had answered letter B, explain the need for blood thinners, do we need to administer blood thinner because of the chest pain? Does that have that therapeutic effect to relieve the chest pain? Or does it or is it really indicated for a patient with aortic stenosis? Not usually, guys. Okay, the blood thinners will be recommended to the mitral valve regurgitation. Okay, it will be indicated to that problem, but not for the aortic stenosis. All right, so this is wrong over here. Again, let me just clarify. Blood thinners are not prescribed for or indicated for aortic stenosis. Now, letter C, advise using sublingual nitroglycerin for pain. This is not a coronary artery issue. It's not about the vasospasm of the coronary artery. Stenosis maybe? No. The problem here is basically the aortic stenosis. The decreased oxygenation to the body or decreased blood flow to the rest of the body, the coronary arteries, need to be dealt with accordingly just by a simple rest. Okay, not nitroglycerin. Letter D, raise the head of the bed at 60 degrees angle. Will that decrease the aortic stenosis? No, it doesn't. It will only decrease the venous blood return. Only decreases venous blood return. Okay, but not address the aortic stenosis manifestation. So resting is the answer. Okay. Now let's move forward to the next question, number 7. A patient with a new mechanical mitral valve needs discharge teaching. What should the nurse emphasize? Is it A, take daily aspirin for anticoagulation? B, learn to take the radial pulse accurately? C, undergo frequent blood tests? And D, avoid physical activity for a month. A, take daily aspirin for anticoagulation. B, learn to take the radial pulse accurately. C, undergo frequent blood tests. D, avoid physical activity for a month. And we are talking about the mechanical mitral valve. What is the correct answer here, guys? Okay, let me wait for your answers. I'm seeing a lot of A's right now. Okay, a lot of A's. I hope that you're correct. Okay. Guys, the aspirin is not going to do anything about it. It will only prevent the clumping of the platelets, but it will not really thin the blood to that level that can prevent the clotting in the mechanical valve. Okay, so this is not going to be appropriate for the anticoagulation. Aspirin will not be effective in thinning the blood. Okay, so this is going to be wrong. What we're going to expect here, guys, is the use of what? The warfarin or the Coumadin. Aspirin will not be effective in preventing the clotting in the mechanical heart valve. What about letter B? Learn to take the radial pulse accurately. Is that going to be correct? Let's find out, guys. Mechanical mitral valve. Maybe what you're referring to, that you're answering letter B, is that probably about the digoxin? But we are talking about the mechanical mitral valve itself, which is a foreign body that can possibly cause blood clots. So monitoring the pulse, radial pulse accurately will not really address that issue. So this is going to be a wrong answer as well. Okay, this is only going to be effective if they are checking their pulse before they take the digoxin. Okay, guys, here's the caveat here. Counting the pulse count for 1 full minute is going to be applicable if they're going to be taking the digoxin. Okay, right? That's the reason why I mentioned something about the pulse count 1 full minute, but that's not going to resolve or prevent any complications with a mechanical heart valve. What about letter C? Undergo frequent blood tests. As like I've said earlier, the patient will be required to get or receive the Coumadin or the warfarin. This will require them to have periodic testing of their what? INR and prothrombin time. So to check for the therapeutic levels, and usually our goal will be between 2 to 3 INR. That's the anticoagulation. Okay. Now, what about letter D? Avoid physical activity for a month. Oh boy, avoiding physical activity for a month can also lead to more complications. So we want to make sure that at least the patient will be able to do some physical activity that they can tolerate. This is wrong. Okay. Allow physical activity that a patient can tolerate. All right. So to wrap up this question, the patient with a mitral valve replacement will require anticoagulation. And what anticoagulant that will be given to the patient? That is the Coumadin. When they take the Coumadin, they need to have at least weekly checking of their blood to know for the INR and the prothrombin time. Okay? The aspirin will not be effective in thinning the blood. It will not. It doesn't have that chemical property to prevent the blood clots from forming. It will cause some what do you call this? It might prevent some kind of like clumping of the platelets, but not necessarily thinning the blood. Okay, it doesn't have that property. Now, moving on to the next question, number 7, or number 8 rather. A post-op heart surgery patient develops pericarditis and has chest pain with deep breaths. Which medication should the nurse administer? Again, a post-op patient, a post-op heart surgery patient I hope so too, because this is getting so disturbing, and I just don't just like the feeling of having the runny nose and that almost sneeze. Don't like that. 8. A post-operative heart surgery patient develops pericarditis and has a chest pain with deep breaths. Which medication should the nurse administer? A. Fentanyl 1 milligram IV. B. Morphine sulfate 4 milligrams IV. C. Ibuprofen Motrin 600 milligrams PO. D. Acetaminophen Tylenol 650 milligrams PO. Okay, our case here is a patient who had undergone heart surgery, but they developed pericarditis after the surgery. And they also have chest pain with deep breaths. Which medication should the nurse administer? Guys, we are talking about an inflammation of the protective lining of the heart. Inflammation. So, look for that medication that can decrease the inflammation. That's my clue for you guys. Look for that medication that can decrease the inflammation, not just about the pain. Because the source of pain really is the inflammation. Without the inflammation, there's gonna be no pain, right? Are you getting the thought here, or the clue? Okay. Well, let's go through the options here. Letter A. If you had answered letter A, fentanyl 1 milligram, is that 1 milligram? Yeah, fentanyl 1 milligram IV. It is going to be less effective. Less effective in for inflammation related pain. Inflammation related pain. I know. Just for a moment. Yeah, probably it will be good for, let's say, 2 to 3 hours. Yeah, boom, gone. But we're talking about a pericarditis type of pain here. How about morphine? Sulfate 4 milligrams. It is also less effective in the treatment of pericarditis pain. Okay, so what is going to be the most effective drug here? Ibuprofen. Motrin 600 milligrams PO. This is going to treat the inflammation in this patient with a pericarditis. Treats inflammation. Yeah, So you really need to educate your patient, guys. The patient probably would think, hey, why are you giving me an oral medication that, do you think that this is just like a headache? Of course not, right? You need to educate the patient about the therapeutic or the drug action. What does the medication, what is the correct, what do you call this? The mode of action rather. What is the therapeutic effect of the drug? Will this only treat the pain or will it address the inflammation? And the issue here is on the pericarditis. It will treat the inflammation. So we are going to select letter C, ibuprofen. It is going to work. Okay. Fentanyl, morphine, those are opiate medications. Probably this is going to not, will be treating the pain, the immediate pain, but not really treating the inflammation. Okay. So we're not talking about the severity, like the scale from 0 to 10. No, that's not the object of this test question. We are talking about targeting that kind of pain the patient is having. All right. What medication can resolve the issue? Okay. It's not about the pain level because we don't have that information there. Nothing about pain level of 10 out of 10 or 8 out of 10. We don't have that information. Our goal here is to treat the cause of pain, which is the inflammation. So same thing with letter D, acetaminophen Tylenol, 650 milligrams PO. It will not really address the inflammation effectively. Okay. So yeah, looks like very simple. It is a non-steroidal anti-inflammatory agent. Yes, thank you, Munther. This is a non-steroidal anti-inflammatory agent that is effective in reducing the inflammatory process in the lining of the heart. Okay. Number 9, for a patient with infective endocarditis of the tricuspid valve, the nurse should watch for which complication. We are looking for complication here, guys. Infective endocarditis of the tricuspid valve. The nurse should watch for which complication. Is it flank pain? Is it enlarged spleen? Is it C, shortness of breath? Or D, changes in the mental status? We're looking for a complication here in this scenario. For a patient with infective endocarditis of the tricuspid valve, do you still remember the tricuspid valve location? It's right here. Tricuspid valve. We are looking for a complication here, guys. All right. Will it cause flank pain? Do you think it can cause flank pain? No. We are talking onto the right side. We're talking about the right-sided problem here, tricuspid valve. So flank pain is going to be more associated with left-sided valve embolization. Associated with left-sided embolism. Okay. What about the enlarged spleen? This is going to be associated with left-sided valve involvement. Left-sided valve involvement. Now, what about the shortness of breath? Yeah, the shortness of breath is a sign that the patient has already developed pulmonary embolism. Manifestation of pulmonary embolism. Okay. So, having this kind of problem here, infective endocarditis, we definitely need to treat the infection before it can complicate into the heart valve problem, okay? Because it can lead to pulmonary embolism. What about letter D, changes in mental status? Well, this is less likely from the right-sided valve emboli. So we're going to eliminate that as well. So the most anticipated complication for an infective endocarditis is what? Pulmonary embolism. And look into the anatomy of the patient's heart right now. Tricuspid valve is the target site. Oh God, have not gotten one right, and NCLEX is coming. God help me. I hope that you will be able to get some more insights, AJ. Okay. When is your NCLEX test? Anyways, guys, with the blood clot, that could potentially go into the lungs, right? It's going to be easy for this blood clot to lodge into the lungs with its pathway into the pulmonary artery. Yeah, pulmonary embolism is the most identified complication in IE. Okay. All right, let's move on to the next. 10. July ending. 3 days for June. You still have time. You still have time. You're going to have to focus into these questions, AJ. Now that you know that you have limited, what do you call this? Power to answer these type of questions, especially with this valvular heart disease. Focus into these areas where you are at the weakest, okay? So you yourself would know for sure where you're not really quite strong, right? So make sure you do more practice tests involving valvular heart disease, anything like this, of any of these kind of questions. All right, let's move forward. Number 10, a patient with severe mitral stenosis and regurgitation on furosemide and nitroprusside shows a sudden drop in pulmonary pressures. What should the nurse check first? Again, the test question stated, a patient with severe mitral stenosis and regurgitation on furosemide and nitroprusside shows a sudden drop in the pulmonary pressures. What should the nurse check first? Is it A, 12-lead EKG? Is it B, blood pressure? C, lung sounds? D, urine output? Severe mitral valve stenosis and regurgitation. And the patient is given furosemide or on furosemide, and they are also taking nitroprusside, which is basically a medication that could potentially drop the blood pressure, right? It can. And so here we have the complication. Yeah, it is a medication that will aid in the patient with pulmonary hypertension. So they're going to get the nitroprusside. However, the combination of the furosemide and the nitroprusside, not a good mix. There is pronounced hypotension. This is a vasodilator, guys. A vasodilator and a medication that can decrease the fluid. Yeah, it will really cause the hypotension. And so what you should do here first, are you going to do the 12-lead EKG, the blood pressure, the lung sounds, urine output? Easy to spot. Check the blood pressure, guys. It will cause that blood pressure to drop. So check and to confirm if they really had a low blood pressure. So it is said here, shows a sudden drop in the pulmonary pressures. Remember about that device that we use to check for the pulmonary artery pressure, it's telling us that the pressure inside the pulmonary artery has already been going down. So we want to make sure to confirm that we are not, or to confirm that the patient really has a low blood pressure, then check the blood pressure. As easy as that. Okay? The medications that we're talking about can cause hypotension, so check the blood pressure. If you had answered the letter A, 12 lead EKG, this is only intended for chest pain or to check for arrhythmias, right? If you had answered lung sounds, will the lung sound confirm that there is going to be a drop in the blood pressure? I doubt. No. The lung sounds will not aid in determining that the patient's blood pressure is going down, so it will not help, okay? Now, what about letter D, urine output? That is also incorrect, but this is something that can be done. Excuse me, after checking the blood pressure. All right, you can do the urine check once you did the blood pressure check. All right, so our incorrect answers are letter A, letter C, and letter D. We are left with letter B. All right, so what is the goal for this test question really? You have to prioritize your assessment that will address a most immediate life-threatening condition. Look for the immediate life-threatening condition. Which is basically the hypotension. Okay, so guys, it's very important for us to really recall the drug action or the side effect of the medication. So again, think about the side effect or the end result of getting a nitroprusside or giving the nitroprusside and the furosemide. All right, so we still have quite a few more test questions to go, but here am I am promoting our course at Stancoast, NCLEXcoaching.com. We are inviting you to enroll to that comprehensive course. Make sure that you are able to be ready for the test. Make sure that you will undergo the 3,000 NCLEX style questions. And we do have our freebies as well. If you are one of those students that would be more interested with animated videos, we do have those as well. You will be able to access our course for the entire 6 months, and you can do the access, or you can access this 24/7. So we are really encouraging you to sign up for this course. Thank you. Now let's move forward, guys. Where are we at? Answer letter C. We're done with this. Ibuprofen. Okay, we're almost there. Lung sounds. Okay, we're done. Number 11. A client with mitral stenosis is preparing for valve replacement surgery. Which pre-surgery regimen is most crucial to follow? A client with mitral stenosis is preparing for valve replacement surgery. Which pre-surgery regimen is most crucial to follow? Is it A, medication therapy, B, diet changes, C, activity limitations, D, dental care? We're talking about pre-procedure. So what would be that treatment or treatment that will be helpful for this patient before they undergo the valve replacement? Most crucial, guys, most crucial. High priority. What is that? Before they are going to be sent for the valve replacement. Okay. The correct answer here is going to be letter A, medication therapy. Okay. Remember that there's so many medications that we have talked about earlier about the different therapies. Let me go back to that page. In general, guys, we have so many things to make sure that the patient is taking before the procedure is done. Think about the diuretics. The patient has that mitral valve issue. They're going to end up with the left-sided heart failure. They're going to have fluid overload. So definitely they're going to need any of these diuretics. And possibly they're also going to need the afterload reducing agents, the ACE inhibitors, or maybe the ARBs, or it could be the beta blocker, or it could be the calcium channel blocker, or the vasodilator, or it could be the digoxin, or the anticoagulant. Okay, so the anticoagulant that we are talking about here is just not about post procedure, but this is also going to be part of the therapy before any placement of any graft. Okay, so there's a whole lot of medications that we will be making sure that the patient is compliant about. Make sure that they have taken the diuretics, any of the afterload reducing agents, or the inotropics, or the anticoagulants, especially the warfarin. So going back into that question, where were we? Oops, not that one. The medication therapy is very crucial in order that the patient will have reduces complications. Procedure complications. All right. What about letter B, diet changes? Do you think that diet changes would be as high as the medication therapy or higher than that? Yeah, it's important, we know. But this is not going to be as immediately critical as to compared to the medication therapy. What about letter C? Activity limitations. Will that really help the patient? Will that place higher priority? I don't think so. The activity limitations might be necessary to reduce the symptoms and could probably prevent further strain into the heart, but this is not going to be as crucial compared to the medication therapy compliance. Okay. Now, what about dental care? Why dental care is wrong in this scenario? The reason is that it can prevent, it is useful in preventing the endocarditis. Let me just write it here. So prevents infective endocarditis, but not the immediate concern, which is basically the pre-surgery. Okay. So in which way dental care is necessary? So we mentioned earlier that dental care is supposed to be done when the patient has that mitral valve regurgitation, and if they have any history of blood clots. Okay. And also if they have any history of blood clots as well, infective endocarditis. Remember about that AJ Ike, about that antibiotic earlier that you thought of providing to the patient or giving to the patient? There is going to be a need for this patient to take antibiotic therapy if they have the mitral valve regurgitation. Okay. There's also dental care before the procedure. I mean, hang on a sec. Yeah, as I've said earlier, this can prevent the infective endocarditis. Yeah, it can help prevent that. However, the dental care will not address the other issues involving the entirety of the medical or the procedure, okay? So this is only limited to preventing infective endocarditis. It will not prevent other complications. I hope that makes sense now. AJ, does that make sense now that the dental care is not going to fully cover the patient's pre-op treatment? Okay, so here, better coverage, but here this is going to be limited coverage. Does that make sense? In preventing complications. All right, so that's my simplest explanation about the dental care not really being the priority for, I mean, just the selection itself. I mean, it is a good intervention. It is a high priority, but it's not gonna encompass a whole lot of stuff. Okay, again, it's only limited to preventing IE. All right, not really the other problems like the blood clot, the hypertension and stuff. Okay, all right. Alrighty, let's move on to next item number 12. Preparing a client and their family for an ICU stay after heart surgery should include which information? Is it A, the client will be in the ICU for 5 days? B, the client will sleep most of the time? C, the ICU environment is quiet and calm? Really? Is it quiet and calm in the ICU? D, pain relief medication will be provided. Question number 12. Preparing a client and their family for an ICU stay after the heart surgery should include which information? Is it A, the client will be in ICU for 5 days? B, the client will sleep most of the time? C, the ICU environment is quiet and calm? I wish so. And letter D, pain relief medication will be provided. So what is your answer this time? Why should? What would be that piece of information that we're going to give to the patient and their family? Why they need to stay in the ICU after the heart surgery? Why? Is it A? Let's find out. It is incorrect, guys. This is wrong. Letter A is wrong. This is incorrect. Why? There is no need to stay in the ICU for 5 days. There's no point of, let's wait too long, okay? It doesn't require that. Not necessary. What about letter B? The client will sleep most of the time. Well, that is not true. Most of the time, the client will not be able to relax and sleep. The ICU is so busy. There's so many noise going on in there. Frequent vital signs, frequent assessments. the patient will have disturbed sleep in this environment. That is also wrong. What about letter C? The ICU environment is quiet and calm. That is false. We are left with letter D. Guys, pain relief medication will be provided. Remember about the surgical procedure? Remember that in order for them to post cardiac surgery, what's important here is to make sure that the patient will be doing those exercises. What I'm talking about is the use of the IS, the cough deep breathing exercises, and there's so many more. We're not just treating the pain, but also making sure that they are watched for any life-threatening arrhythmias during the acute phase post-op. We want to make sure that this patient is going to be monitored accordingly, one-to-one nursing care. Okay, so basically this will require one-to-one nursing care. They're not appropriate to be placed in a med-surg unit during the acute phase. No, it's not going to be safe for the patient. All right. So our best answer here is letter D, pain relief. Of course, pain relief will be much more attended at this point. It needs to be addressed right away, as we are going to be looking out for more complications during the acute phase. Remember that while they're going to be starting to wake up, we need to really start doing or encouraging them to do the coughing and deep breathing exercises, involving them with the use of the incentive spirometer. But before they can proceed with those things, we want to make sure that there is pain control. All right. But like I said, it's just not about pain control, because this is something that we can manage. The pain control is something that we can manage in the med-surg, but there are so many other stuff that will be done for this patient in a ICU setting, okay, that med-surg nurses cannot do. All right, so our correct answer here is letter D. Number 13. A client post mitral valve replacement has persistent bleeding from the incision. What actions should the nurse take? Select all that apply. Is it A, give warfarin, B, check CBC, INR, PTT, platelets, C, ensure blood products are available, D, monitor chest tube drainage, E, start a dopamine drip if blood pressure is below 100 systolic. The question states, a client post mitral valve replacement has persistent bleeding from the incision. What action should the nurse take? Select all that apply. A, give warfarin, B, check CBC, INR, PTT, and platelets, C, ensure blood products are available, D, monitor chest tube drainage, and E, start dopamine drip if blood pressure is below 100 systolic. Okay. Let's eliminate letter A, guys. The patient already has persistent bleeding. They already have persistent bleeding, so we're going to eliminate letter A. Contraindicated. What about letter B? Yeah, we definitely need to check the CBC if there is now a reduction in the hemoglobin, red blood cells, INR, PTT, and platelets. Okay. Now, what about letter E? Start a dopamine drip if blood pressure is below 100 systolic. Would that be appropriate? We're going to eliminate that one because before you're going to have to proceed with administering the dopamine before you administer the dopamine as ordered, you're going to make sure that you are treating the hypovolemia first. Okay, treat hypovolemia first with IV before considering the dopamine. Okay, so that is going to be the correct answer. That is the explanation why E is wrong. We're not gonna immediately start a dopamine drip if blood pressure is below 100 systolic. We're gonna have to treat the hypovolemia first. So what would be the correct answer here? We're gonna have to check the CBC, the INR, the PTT, and the platelets. And we're also going to what? Ensure that the blood products are available. Okay? Because of the persistent bleeding, there is going to be probably anemia already. So we need to make sure that there is available packed red blood cells. Okay? And maybe if the patient will need the fresh frozen plasma, maybe a deficiency in the clotting factor, then the fresh frozen plasma would be helpful in controlling the bleeding as well. But we're only ensuring that the blood products are available. We're not really getting the blood product yet, just ensuring. So this is another good answer for this test question. Okay. All right. Let me just check real quick if the message. Now, moving forward, guys, our correct answers are the following. We have letter B, we have letter C, and what else? We also have letter D. What is in letter D? Monitor chest tube drainage. Yes. The reason that letter D is one of the answers is because the mitral valve surgery itself can require the use of a chest tube drainage, and this is going to help remove the air, the fluid, or could be the blood from the chest cavity after the surgical procedure. Okay, can you hear me now? I hope so. All right, so again, letter D is another correct answer. This will involve the use of the chest tube drainage. So we are going to monitor the chest tube drainage every now and then in order to monitor for any complications, any leaks, any what else? Leaking, bubbling, those kind of things. Entry of the atmospheric pressure into the chest. And so the correct answers again, we have letter B, C, and D. All right. Okay. Let's move on to the next question, number 14. Teaching a client with mitral stenosis about preventing endocarditis should include which dental care instructions? Okay, here we go. Preventing endocarditis. Teaching a client with mitral stenosis about preventing endocarditis should include which dental care instructions? Select all that apply. Is it A, brush twice daily? Is it B, avoid electric toothbrushes? C, take antibiotics before oral surgery? D, floss daily. E, have regular dental checkups. And F, use antibiotic mouthwash daily. Question states, teaching a client with mitral stenosis about preventing endocarditis should include which dental care instructions? Select all that apply. Is it A, brush twice daily? B, use or avoid rather. Oh my God, I'm getting confused. Avoid electric toothbrushes. C, take antibiotics before oral surgery. D, floss daily. E, have regular dental checkups. And F, use antibiotic mouthwash daily. All right, let's go through the options. Letter A. Letter A, brushing the teeth twice daily. Of course, we're gonna encourage that. What about letter B? Avoid electric toothbrushes. Not contraindicated, guys. Not contraindicated. So should not avoid that. Indicated. All right, what about take antibiotics before oral surgery? Or, yeah. All right. What would be your answer here? Is C a good answer? This is wrong. The reason that letter C is wrong, it is because antibiotics are only taken okay, these are only taken for patients with prosthetic valves. We're talking about mitral stenosis. Okay. All right, not the regurgitation. All right, so we are not gonna take this as a good answer. We are gonna eliminate. What about letter D? Floss daily. Yeah, we can promote the flossing daily. What about have regular dental checkups to maintain oral health? Of course, that is also correct. What about letter F? Use antibiotic mouthwash daily. It is not needed to be taken daily, all right? And there's no indication really about, excuse me, there's no indication that the patient will get the benefit about an antibiotic-based mouthwash. So our answer is only limited to letters. Again, A, letter D, and E. A, D, and E. Okay. Let's move on to number 15, guys. Post-mitral valve replacement. Which activity should a client avoid until their first month post-surgery checkup? Number 15, post-mitral valve replacement. Which activity should a client avoid until their first month post-surgery checkup? Is it showering? B, lifting over 10 pounds? C, gradual walking? D, light housework? What would be your answer here, guys? Post-mitral valve replacement, which activity should a client avoid until their first month post-surgery checkup? Is it A, showering? Is it B, lifting over 10 pounds? C, gradual walking? And D, light housework? All right, let's filter these answers. Letter A, showering. Showering is allowed. Okay, showering is allowed provided that the dressing site is covered, okay, and the incision is going to, here it said should avoid until their 1 month post-surgical procedure. So basically, this will encompass that first 30 days right after the procedure, okay? So what is going to be done here? We want to make sure that they can still take a shower. That's very important, right? But we have to really be careful with the dressing site. Make sure that they're going to have to cover that dressing immediately after the surgery. They're not going to have to, they're not supposed to make the dressing site wet, so to prevent any kind of infection. Now, letter B, lifting over 10 pounds of weight or 4.5 kilograms. This is the correct answer. Letter B. Why? 10 pounds is quite a significant amount of weight that can cause strain into the sternum or to the heart itself. And so avoid this in order to promote healing of the sternotomy, the surgical site. So there should be less strain to the surgical site, okay? Prevent strain to the surgical site. All right. What about letter C, gradual walking? Are you supposed to avoid that or prevent the patient from having a gradual walk? Of course not. That would really help the patient in gradually increasing their activity according to their tolerance. So make sure that this is part of their care plan in order to achieve a faster recovery, okay? It will also promote circulation. It will promote muscle tone. Overall recovery is going to be our end goal here. What about letter D, light housework? Are you supposed to avoid that? Of course not. Light housework would really be applicable. It's nothing against, or not contraindicated, I should say. You should allow this patient to do this kind of activity in order to remain active and also to achieve independence. Okay? Increase active lifestyle. Forgive me. Oh boy. And also independence. Okay. So here, our goal for this test question is to avoid any of those choices that are not supposed to help the patient's recovery. So again, lifting heavy objects is highly contraindicated, and we have that information about the weight, at least 10 pounds or 4.5 kilogram. Any activity that can cause strain to the heart or the surgical site need to be avoided. Alrighty, guys, we are at the last test question today. I really thank you for your patience, even though I am sick. Thank you for your active participation, and I hope that you are learning today. We are going to be moving forwards with the next topic. Tomorrow, we'll be talking about hypertension. There's so many things that you need to know about with the pharmacology, not just about the routine stuff. So we'll focus on those things tomorrow morning at 9 p.m. Eastern Time. So I'll see you again. Everyone take care, and I hope that you have a good rest of the day. Thank you, and bye-bye.